Let's hunt to find the right answer. We're going to talk about leukemias. We're going to talk about myelogenous leukemias. Here we go. You've got a super high white blood cell count. It's at 58,000. There's a ton of immature myeloid cells. You got basophilia and eosinophilia. And you've got a low leukocyte alkaline phosphatase. That's very important. Okay, so these are the signs of chronic myelogenous leukemia. So that's CML. Let's talk about the other ones and why it's not those. ALL. This one would have greater than 25% lymphoblasts, right? So acute lymphoblastic leukemia, you'd have the lymphoblast greater than 25%. Here it's only 1%, so it's not ALL. How about AML? Well, acute myelogenous. So there you'd see a lot of blast cells. We only have 1%, and also typical AML age is going to be older. So AML will have older adults, white blood cells are not going to be as high, and you're going to have like 20% myeloblasts and aurods. So it's not AML. All right. CLL would have your mature lymphocytes. So CLL is not the answer here. Leukemoid reactions, those have mature neutrophils. So you'd have a high LAP. Follicular, that's a lymphoid tumor. Parasitic would be eosinophils. So just to run through these real quickly again. ALL in children, and it's going to be lymphoblastic. That's what the name is, lymphoblastic. So in our patient who's like 45, less than 2% blasts. So it's not it. Acute myelogenous leukemia, that's older adults, greater than 20% myeloblasts, and also you could see aurods. The patient only has 1% blasts, and so there aren't enough blasts for it to be acute myelogenous leukemia. It's also a little bit too young, even at 45. Follicular lymphoma is 14 to 18. Chromosomal translocation, that's the BCL2 overexpression. So the cells would be small, cleaved lymphocytes and follicles. So you wouldn't have those peripheral smear changes. It's a lymphoid neoplasm. Chronic lymphoid leukemia, so CLL, it's going to be elderly. So this person's 45, so a little bit too young for your CLL, but smudge cells is what you see on the smear, and we don't see the smudge cells, so that's a very important sign. CD5, 2023 positive, and this patient has myeloid precursors, not your lymphocytes. That's why it's not your lymphocytic again, sort of like how ALL was wrong as well, lymphocytic. Chronic myelogenous leukemia, yep, white blood cells are elevated, myelocytes, increased basophils, low LAP, translocation, 9 to 22, BCR-ABL fusion, that's good. Burkitt's lymphoma, I like to call it Burkitt lymphoma because it's in children and young adults. So the genetics is 814, starry sky. If it's endemic, you see the jaw and the sporadic in the abdomen. HIV associations. That's also a lymphoid tumor, so it's not myeloid precursor. Diffuse large cell B lymphoma. This is an adult, rapidly enlarging, CD20 positive. There's no basophilia as well, so it's not that. Parasitic infection, that's increased eosinophils. You'd see eosinophilia, not myelocyte or basophilia. Leukemoid reaction, that's severe infections. LAP would be high or normal here, importantly. And they have a low LAP. Fungal infection, that'd be immunocompromised patients. Symptoms would be necrotic turbinates and facial pain and fever. So this patient's not immunocompromised, and so that's not going to be it. So those are your big signs to look out for when differentiating between choices if you see a big white blood cell count with immature cells. Hopefully this is helpful. Like and subscribe.